Good afternoon. My name is Nancy Trick and I'm the Manager of Clinical Education at Teleflex. On behalf of all of us at Teleflex, thank you for joining us for the first of a three-part series of webinars focusing on the arterial catheterization. Following our presentation, we will have a question and answer period. Please submit your questions during the course of this webinar using the GoToWebinar question pane on the control panel. Speaking on our very important topic today is Amy Barden. Ms. Barden is a respiratory care supervisor and vascular access specialist at Banner Australia Medical Center, Phoenix, Arizona. She has nearly 20 years of supervisory experience emphasizing on ICU and CCU as well as invasive hemodynamic procedures and monitoring, including CVC and PICC insertions. Amy recently presented at the American Association for Respiratory Care National Conference on the growing world of vascular access management, what every RT should know. Amy is the current president of the Arizona Society for Respiratory Care and is an active member of the Association for Vascular Access. Amy has presented extensively on arterial, CVC, PICC insertions to a multidisciplinary audience. Please join me in welcoming Amy to our webinar on arterial catheter insertion, care, and maintenance. Everyone should know that this webinar has been accredited for one contact hour for nurses by the Board of California, State Board of California, provider number 14477, and by the AARC for one contact hour of continuing respiratory care education. To receive contact hours, please listen to the entire webinar and then follow instructions at the end of the program. Amy has no disclosure or any conflicts of interest related to this presentation. At this time, I would like to present our program as well as Ms. Amy Barden. Thank you, Amy.
Thank you, Nancy. Welcome to Arterial Catheter Insertion, Care and Maintenance. The learning objectives for this program include discuss insertion techniques for arterial catheter placement, discuss site selection, describe the use of ultrasound for vessel visualization and catheter insertion, and review daily maintenance and bundle strategies related to arterial catheters. The background of arterial catheter insertion dates back to the 1950s, and in today's age, respiratory therapists, registered nurses, nurse practitioners, and physicians alike all place invasive arterial catheters. Invasive hemodynamic monitoring is beneficial in the critically ill setting. Continuous monitoring of blood pressure, serial blood gases, and for the facilitation of frequent titration of drugs. Technology, such as ultrasound, has improved insertion success and established guidelines through several organizations in regards to care and maintenance is now available across all disciplines. Indications for arterial cannulation include, as discussed, the need for titration of inotropes or vasopressors, patients with hemodynamic instability, hypertension, and hypertensive crises, shock, multi-system trauma, septic patients, patients in cardiac arrest, and traditionally in cardiac and general surgery. Respiratory failures included in this group for the need for serial blood gases. Intra-aortic balloon pumping has an arterial catheter of its own. Mechanically ventilated patients to better titrate the ventilator settings. And then again, the need for arterial blood gases. Contraindications for arterial cannulation do exist, and as practitioners we should all be well aware. Lack of collateral circulation, especially in the radial area, limits circulation or poor capillary refill to the extremities is a contraindication. A negative Allen's test warrants a site selection other than the right to left. A history of lymphedema to the extremity, presence of an AV fistula for decreased flow, signs of skin or infection near the proposed insertion site, because we don't want to be accountable or increase the risk of infection to an insertion site. We want to use the cleanest site available. History of peripheral vascular disease, as that extremity may have lower perfusion or circulation and our pressure may not be most accurate. And caution should be used on patients receiving thrombolytic therapies because the risk of bleeding at the site, and depending on the insertion site with the gauge of catheter, there might be an increased risk of bleeding. Complications also associated with arterial catheter insertion include thrombus, exsanguination, air embolus, which is usually related to the pressure transducer setup that needs to be adequately flushed prior to assembly and attachment to the extension tubing. A hematoma, which normally is referenced when a transfixion approach is done, where you go through and through the vessel, and that's a technique that we do not advocate for. Arterial spasm, which is normally related to insertion technique. Infection, and we're going to talk about strategies in which to reduce risks of infection. Tissue necrosis, and that's generally in patients who have decreased circulation at the site or maybe are being trunk perfused because they're on high doses of vasoconstrictive drugs. Peripheral ischemia also lives in that group of patients, as well as peripheral nerve damage, and that's usually caused because the radial artery is very much bound by nerves. So reducing infection risk, and what can we do as practitioners to reduce risk for these invasive procedures? We've aligned ourselves with the Central Line Bundle as clinicians and with evidence-based practices to improve patient outcomes of vascular lines. These approaches would also be used in facilitation of placing arterial catheters. Hand hygiene, the use of max barrier precautions during insertion, use of the chlorhexidine-based solution for skin antisepsis, site selection with avoidance of the femoral region, especially in the adult patient, and daily review of line necessity with prompt removal of unnecessary lines. We're going to walk through each one of these as it pertains to arterial catheters. Hand washing, the cornerstone of aseptic technique, and throughout the procedure of arterial catheter insertion or central venous catheter placement for that matter, hand washing is done several points. This should be performed on assessment, after preparation, and before insertion. Palpation of the insertion site should not be performed after application of the antisepsis unless you are sterilely gloved. Maximum barrier precautions. Non-sterile cap and mask, sterile gown, gloves, and large sheet drape are used in maximum barrier precautions. This is related to the femoral and the axillary site as requested and recommended by the CDC. Use maximal sterile full body drape. Use special care of application of gloves, which is a closed gloving technique where your hands go through your gown and never exposing your fingers until your gloves are applied. And then immediately address episodes of contamination. And when I train people, I like to say, a pair of gloves is 40 cents, life is precious, and a line sepsis, whether it be arterial related or CVC related, is $40,000 to $60,000. So let's walk through skin antisepsis. When preparing the skin, a 2% chlorhexidine gluconate and 70% isopropyl alcohol is used. Cleanse in a back and forth friction motion, allowing the antisepsis to permeate the pores. Now in the olden days, and I say that because I've been doing this for just a little while, we used to use betadine. And what we used for the betadine was appropriate at the time. Chlorhexidine today is better. Betadine at the time would be a 3-step process. We apply from the insertion site out, insertion site out, insertion site out, and then we were supposed to let it dry and flake off. As practitioners, time is precious, and I don't think that we ever allowed that to actually work. So chlorhexidine, just for application, is much better to use. So skin preparation solution should be applied to clean skin, meaning the skin should actually be cleaned prior to preparation. It can be washed with soap and water, simple solution. And then cleanse the catheter insertion site by applying the antiseptic solution. Apply the back and forth friction motion with the chlorhexidine applicator. Allow to dry, and do not blot or blow it dry. Relevance to sterile field. When you're using standard kits, you open the kit in a sterile manner by reaching to the opposite corner and pulling the wrapper towards you. You never reach over the sterile field for possible contamination. Prepare the package and gloves and set aside. A cap, mask, and eye shield are done first, and regardless of insertion site, a cap, a mask, and eye shield are required for all insertion areas. Avoid touching external surfaces, including the skin. As a clinician, the first thing we want to do is prep, drape, and touch our skin site, and that should be avoided. Sterile drapes. Use the full body sterile drape for femoral and axillary catheter placements. That is the CDC recommendation, and those are the two sites that require maximum barrier precautions. Do not move or rearrange the drape once in position. Clinicians maybe have not picked their spot, or they've prepped a wide array of area, but there's an intentional sticky adhesive area on that full body drape that needs to be stuck to the prepped area. If the patient touches the drape, cover the area with a sterile towel. Use a small fenestrated drape for radial and brachial insertions, and that's recommended by the CDC. So just to recap, femoral and axillary insertions are max barrier. You control traffic in and out of the room. You also do hat, mask, sterile gown, and full body drape, and sterile gloves. For radial and brachial insertion, you use a small fenestrated drape, cap, mask, and sterile gloves. Sterile field awareness. Sterile and non-sterile items are always kept separately. The edges of the sterile field, you should maintain about a 2-inch parameter not to touch or break sterility. Items or gloves such as gloves are never drop below the waistline, so sometimes you see people and they're holding their hands above their chest. That's to maintain sterility. Items under a sterile drape are always considered contaminated. So you would never prep a field and walk away. You'd never set up a tray for a case that was happening in an hour and walk away. You as the clinician need to be aware that once opened and left so that somebody else might touch it, it should be considered contaminated. Sterile packaging is, with overwrapping is replaced by a full sterile drape. So let's review some of the insertion sites. So the Centers of Disease Control specifically address site selection based on infection risk to our patients. Guidelines are now available to support insertion techniques and site selection. So the radial and brachial or dorsal pedis are the first sites of choice for the CDC, and the femoral and axillary sites pose increased risk of infection, therefore they should be delineated to the end and used as a last resort. There are some indications for femoral insertion, and we talked a little bit about the vasoconstrictive agents and trunk perfusion pressure. So if you have a patient that's on high drips and they're in septic shock, a true circulatory pressure might only be gained from a femoral insertion that gives true trunk circulation, where a peripheral arterial catheter such as radial or brachial may not be correct, and you may end up titrating drips according to a false pressure. So the radial artery, it's the most common site for arterial cannulation in the critically ill patient. You can see it there in the diagram. It's supported by the brachial artery and detaches between the ulnar and the radial. It's superficial and easily located and palpable. It provides collateral circulation with the ulnar artery, and it minimizes risk of ischemia complications should the artery become occluded because it's supported by ulnar flow. It's the first site of choice, as I said, for arterial cannulation. It provides easy access and allows the patient full range of motion. Collateral circulation is promoted by the ulnar artery, which reduces arterial line-associated complications such as hematoma or clotting or thrombus. So collateral circulation. Establish collateral flow prior to cannulation. If collateral flow is low or absent, choose another site. Radial thrombus in the wrist with poor or absent flow may result in ischemic injury or a limb loss. Collateral circulation should be assessed with a modified Allen's test or Doppler and should be charted within your documentation. So let's walk through the modified Allen's test. First, you're going to instruct your patient to clench their hand in a tight fist. While their hand is clenched, digitally compress both the ulnar and the radial arteries. Instruct the patient to open their hand partially. The hands and fingers should appear pale at this point. Remove the pressure from the ulnar artery, and the entire hand should return to normal color within 10 seconds. And if that happens, it's a positive Allen's test, and that can be documented, and that demonstrates a good site for line insertion. If the patient's unable to clench their wrist and do a modified Allen's test, then you can do a Doppler assessment. Occlude the ulnar and radial arteries. Place the Doppler probe distal to the radial artery, proximal to the thumb. Confirm occlusion by absence of a pulsatile sound. Release the ulnar artery. If the pulse is restored with continued compression of the radial artery, collateral circulation is confirmed and therefore can be documented, and that is an appropriate site for line insertion. The brachial artery. Larger and deeper than the radial artery. It's also the second site of choice for line insertion. It's the primary source for circulation to the radial and ulnar arteries. So as a clinician, I say to you, if you cannot palpate or cannulate the radial artery and you don't have great circulation and you can document that, you would never insert a line into the same side brachial artery. Caution must be exercised when cannulating the brachial artery because of thrombus may occur and circulation to that extremity would be faulted there, and that could result in limb loss. Like I said, it's the second site of choice per the CDC guidelines. You can either cannulate with a 20-gauge intravascular catheter or a 3 French sheath type single lumen catheter. The sheath type lends itself to a longer catheter because the brachial in some patients is much deeper than the radial catheter, or the radial artery, excuse me. This site restricts arm movement and has an increased thrombus formation and may cause ischemia to the extremity. So both radial and brachial sites that we've reviewed require that small fenestrated drape, hat, mask, and sterile gloves. Now to the femoral artery. The femoral artery supplies the greater part of the lower extremity. It's direct continuation of the external iliac artery as described in the picture on your screen. It provides the truest blood flow measurement during shock and vasoconstriction, as I discussed. So the body is very, very smart. It will peripherally shut down to circulate the heart and the head. And it's important that we know as clinicians that when we see a patient that's mottled, that's cold, that's on high doses of vasoconstrictive agents, that the true blood pressure probably can only be gained from a femoral approach. It is the third site of choice for arterial catheter insertion. It does have the highest risk of infection due to high bacteremia colonization in that region, and that true is aligned with the CBC same concept that central venous catheters should be avoided in the femoral region, and the data that's supporting central venous catheters and arterial catheters is aligned for the infection prevention for high bacterial colonization. So consider use of chlorhexidine impregnated sponges dressings on insertion. This is different than any of the other sites that we've discussed. Immediately once a line is placed in the groin, regardless of the type of catheter, a chlorhexidine impregnated sponge is recommended due to the higher risk associated with this site. Maximum sterile barrier precautions should be used. Therefore, traffic should be controlled when you're putting lines in these patients, in and out of the room. Everybody should have a hat and mask on, as well as the inserter should have the hat, the mask, the gown, and the gloves with a max sterile barrier drape. So we're going to talk about insertion techniques, and this section, I warn you, is very text heavy, and the reason it's text heavy is because we want you to be able to print this section and use it in your own facilities to create insertion policies and procedures and that are all aligned with best practice. So we're going to walk through first the insertion techniques and then the actual site insertions. So a couple of different ways for catheter insertion is the Guidewire or Seldinger technique. This is the most common technique used today. This is a catheter needle that has the guide wire. Either it's preloaded or you add it to your procedure. Before your procedure, you would dump it to your field. The artery is accessed with the needle at 30 to 45 degree angle. Upon blood return, the guide wire is then advanced into the artery, and the catheter is then threaded over the wire. These are images of the two different kind of catheters that can be used for this procedure, the traditional Seldinger and the integrated Seldinger. And you can see the integrated has the wire with a lever that you would advance the wire right into once you gain access and free flow blood. And the top one is you would actually stick the artery, feed the wire, pull the needle out, and feed the catheter over the wire. The other insertion technique is called direct cannulation. You would insert over the needle over the catheter over the needle, excuse me. So aim towards the center of the vessel at 30 to 45 degree angle. And remember, this isn't visual, that you're actually palpating and you're trying to aim for the center of the vessel. Trying not to transfix the vessel, which means go through and through. On appearance of free flow arterial blood, you'd hold the needle in position and you thread the cannula over the needle into the artery. The tricky part of this procedure is that the cannula should advance without resistance. And the advantage of using the Seldinger technique with the wire is that it easily feeds over the wire, where sometimes it doesn't so easily feed over the needle. So let's talk about anesthesia for these site insertions, because if I was going to have an arterial catheter, I would want my area deadened or numbed. So we're going to talk about injecting a small amount of local anesthetic prior to cannulation. And if you're utilizing ultrasound, which we're going to review, I encourage you to numb with the ultrasound so that you can see the vessel while you're numbing. It also gives you another indicator or a site source. So lidocaine at 1%. You're going to place a 27 to 30 gauge needle directly between the dermal layers of the skin. You're going to slowly inject 0.1 to 0.2, which is not very much anesthetic, until you get a wheal or a bleb. And as clinical practitioners, we all have TB tests, and that really is what that bleb should appear to be like. Always aspirate the syringe prior to injection to ensure that the tip of the needle isn't actually in the vessel. You certainly don't want to be sucking arterial blood out when you go to aspirate checking placement. Subcutaneous injection should be avoided, as sometimes the patient's blood pressure is so low that you'll actually cause smooth muscle relaxation and you'll lose your pulse for a moment. So let's talk about ultrasound guidance and why this has been a big move recently. So ultrasound has become the standard of practice for vascular access device insertions, and I do believe that arterial catheters should be no different. It's an effective visual aid. It reduces insertion attempts. It increases first attempt success. It reduces complications and risk to the patients by reducing total number of attempts. We know that reduces risk of infection. It allows a differentiation between arteries and veins, so you can actually visually see and maybe select side to side differently. And it allows detection of anatomical abnormalities that maybe you wouldn't have seen obviously before if you weren't using ultrasound. So when performing a scan, you would begin with the probe at a 90-degree angle from the area to be visualized. And you can see on your screen two different transverse and a perpendicular view of the vessels. Use plenty of gel because that is what conducts the probe. Hold the probe with your thumb, middle, and index finger. Check the screen orientation. And I say as clinicians that you really want to know your equipment prior to utilizing it. Ultrasounds have a left to right interface. They also have on the probe itself, there's a guide that will show you to be able to line yourself up with your vessel. So really orientate yourself with the process with the ultrasound machine before attempting it on the patient. I like to, when I teach, to go and have each other people ultrasound themselves because it kind of gives them more of a comfort with the equipment. Adjust the screen setting for optimal image and vessel view. And make small movements. As you see on the top of your screen there, the artery up on the top is pretty small in comparison to the screen. Slide your probe and adjust the beam angle to achieve the best transversal image of the vessel, which gives you that nice round image of the vessel. Vessels will appear black circles on the screen. Arteries will be difficult to compress, pulsatile with thick walls, and they're very circular in nature, where veins will be compressible, have a thinner wall, and will appear ovoid or egg-shaped on the screen. Ensure your probe is perpendicular to the vessel wall and scan at about a 90-degree angle. So really the adjunct to, and we'll talk a little further about ultrasound, is patient safety and really successful first attempt passes. And I feel like ultrasound really has been an adjunct to teaching. So new clinicians that are just now learning to place lines and avoid oversticking and oversticking patients and difficult access patients, utilizing ultrasound to bridge that education has been very useful. So now we're going to review catheter insertion. This is that part that's very text heavy, and it's text heavy so that you as the clinician can take these pieces and parts back and create your own policies and procedures. So first we're going to verify that we have the right patient. In anything that we do in healthcare, always verify that you have the right patient. Perform patient education and obtain informed consent if that's part of your policy and procedure. Perform pre-procedure verification and timeout, and this takes 2 practitioners to do, and it should be documented within your charting. Place patient in a comfortable position, supine with arms at the side, assuming that that's where you're going to place the right to left, whichever side you're going to place. Explain the procedure to the patient, and keep them well informed of what you're doing. Gather your supplies and equipment. Wash your hands. This is the first part of that washing your hands. That you're going to see this several times throughout this. Washing your hands is a big part of sterile procedures and invasive catheter insertions. Don mask. Perform your pre-assessment and site selection. Check for collateral circulation using the Allen's test. Pre-assess with ultrasound if available. Wash insertion area with the antimicrobial solution or soap and water. This is that pre-prep stuff that we talked about, and dry with a clean towel. Place a towel roll under the wrist or hand so the hand is dorsal flex and secure. Now this is really a practitioner's choice. There's some kits that come with an apparatus you can lay the wrist against. Some people use a towel roll. Some people will tape the thumb just to make sure that the artery is very superficial. And this is just really is practitioner's preference. It also has to do with the patient. If the patient tolerates the procedure well, or if they're not as well oriented, you might have to secure it with different measures. And then we're going to wash our hands again. We're going to establish our sterile field and drop our supplies into the field using caution to prevent contamination. And like I said before, acknowledging that we had a contamination is cheap and saves lives. So if you contaminate something, just get new stuff and start again. Don your sterile gloves. Prep the insertion site with a greater than 5%, and we talked about in the beginning the 2% standard chlorhexidine gluconate with the 70% isopropyl alcohol. If a patient is allergic to that, you can still use the betadine solution, but we need to make sure that we're very stringent on technique and we allow it to dry and flake off. Apply the small sterile drape to the insertion area. Remember, this is the arterial, this is the radial site, so the small fenestrated drape. Place the sterile probe cover on the ultrasound machine if you're using it. And you really want that ultrasound probe cover to cover the probe and the cabling, so that the cabling can be laid up on your insertion area and you can manipulate the probe back and forth without it falling over. That sterile drape that goes over the insertion site is quite small compared to like a maximum barrier drape. Palpate the artery. When using ultrasound, place the probe over and visualize the radial artery. Administer your lidocaine. And as a clinician that uses ultrasound, I see it a great benefit that we use the ultrasound, we see the vessel, we administer our lidocaine, and that's all a one-step process. It aligns you with the vessel, it kind of aligns you with your ultrasound, it gives you that cognition of a successful insertion. Prepare your catheter and remove the protective sleeve. At this point, as a clinician, you really want to check your catheter, make sure that it's going to come off your needle fine, if that's the type that you're using, or that your wire feeds easily. What you don't want to do is get into the patient's skin and get blood flow and not be able to advance the wire and then question whether it's the catheter, the manifold, or your technique. So hold the catheter at a 30 to 40 degree angle. You're going to puncture the vessel using a continuous, controlled slow motion. Avoid transfixing, and we talked about this, going through and through the vessel wall. Doing that increases the risk of thrombus and bleeding at the insertion site. It also increases your failure rate. Blood flashback in the introducer needle indicates a successful entry into the artery. Stabilize your position of the introducer needle and carefully advance the spring wire guide into the vessel using the actuating lever. Advance the entire placement device a maximum of 1 to 2 millimeters further into the vessel. Firmly hold the introducer needle hub in position and advance the catheter forward with a slight rotating motion over the spring wire guide into the vessel. This just really helps it go in with a smooth transition. Hold the catheter in place and remove the spring wire guide assembly. Pulsatile blood flow indicates a positive arterial placement. Directly connect a 6-inch piece of high-pressure tubing with a one-way distal stopcock. And we're going to talk about this one-way stopcock in the 6-inch pressure tubing a little later. Cleanse the insertion site. Secure the catheter per facility policy. Place sterile gauze and transparent semi-permeable dressing over the catheter insertion site and attach your pressure monitoring setup. And as you see, with a regular radial artery insertion, I always get the question, do you place an antimicrobial patch on this insertion site? And I really want to express to you, 1, to know your infection rates, 2, know if you have a problem, 3, know if through education you've been able to minimize a risk to our patients, and if all of those have failed you, that's when you would add an adjunct per the CDC recommendations, such as an impregnated patch at the insertion site immediately. The only site that we do that immediately for would be the femoral site because of known bacterial colonization. Brachial artery insertion. So this is going to be a little shorter because we're not going to do the step-by-step, but we're going to prepare and prepping and draping. Remember, we're going to use the small drape, we're going to use the chlorhexidine, we're going to have our hat and mask and our gloves on. When we're ready to insert the catheter, we're going to hold this catheter at a 45-degree angle, remembering that the brachial artery is a little deeper than the radial artery, and depending on our patient population, it could go through a lot of adipose tissue. Once a flashback is noted, lay the catheter down slightly, feed the wire, and then advance the catheter over the wire. If a single lumen sheath is being used, hold the introducer at more of a 30 to 45-degree angle and insert into the artery. Once free flow is obtained, advance the guide wire through the needle. Remove the needle and place the sheath over the wire and remove the wire. The single sheath technique works well because some of these brachial arteries are so deep. And you really want to make sure that we aren't doing more procedures than we need to and that we're selecting the best device for our patient each time. So if you have somebody with a nice big arm or lots of adipose tissue to go through, or you utilize the ultrasound machine and you see that the vessel depth is almost the length of your catheter, as a clinician you should consider a better device for that patient. This is an example of an insertion tray with all the components. And then the next step would be to directly connect the 6-inch piece of high-pressure sterile tubing with the distal one-way stopcock. Cleanse the insertion site and secure per the catheter facility policy and procedure. And then place that sterile gauze or transparent dressing, and that antimicrobial patch would be the same indication here as it would be with the radial artery. And then attach your pressure monitoring setup. So femoral site insertion. We know that we need to avoid the femoral site as much as we can, but we know in clinical situations that are relevant for patient conditions, we have to use the femoral site in some situations. So when we're ready to insert that catheter, I would ask you to utilize ultrasound. Visualize the vessel. Decrease the total number of attempts because it decreases risk of infection on an already known high infection rate area. I would also remind you to be very stringent with chlorhexidine prepping and make sure you're maintaining max sterility with a maximum barrier drape. So when this insertion area, you're going to have your catheter ready. You're going to hold your catheter at a 45-degree angle and insert into the artery, whether through visual aid or through palpation. Once a flashback is noted, you're going to lay that catheter down slightly, feed the wire through the catheter, or through the needle, excuse me, pull the needle, and feed your catheter over the wire. If a single sheath introducer is used, you're going to go to 30 to 45-degree angle, insert that into the artery. Once free flow blood is obtained, you're going to advance your guide wire over the needle, remove the needle, and place the sheath over the wire, and then remove the wire. directly connect that 6-inch piece of high-pressure tubing with the one-way distal stopcock, and right now we'll talk about that a little bit. The 6-inch piece of sterile tubing has been intentionally placed in kits and is intentionally being dumped for A-line insertion because it allows us as clinicians to be compliant with CDC recommendations for monitoring setup changes of transducer monitors. So a transduction monitor has to be changed every 4 days or 96 hours, and the distal tubing, this 6-inch piece of tubing with that distal one-way stopcock, allows us as clinicians to change it because, one, it's dumped sterile onto the sterile field, so it's applied to the sterile insertion dressing, and it allows us to change that cycle of pressure transducers without breaking the insertion site itself, without having to go all the way down to the hub. The other thing it does with a one-way stopcock versus a three-way stopcock, it doesn't add any area for a clinician to draw blood out of it. Because if you draw blood out of a stopcock within a transduction setup, that stopcock has to be changed at a 24-hour interval for infection prevention reasons. So that is that reason that that 6-inch piece of high-pressure tubing is in there and that distal stopcock. It also allows you as a clinician to dress the catheter insertion site before hooking up your transducer so that you're sterile throughout the whole process until that dressing and insertion site is totally covered. So then you're going to clean your site and secure your catheter per facility policy. And at this moment, you're actually going to go back one step. You're going to actually place the chlorhexidine impregnated sponge around the catheter at the insertion site for every femoral insertion. Again, for that known risk site. Place a semi-permeable dressing over that catheter insertion site, and then attach your high pressure, your pressure monitoring tubing setup. So considerations for femoral, and we talked about some patients just having to have that insertion site, and our patients are getting sicker and sicker and have less and less vasculature. We see that in the venous side with CVC placements, and we're seeing that certainly in the arterial side. So there is reasons that we have to use femoral, the femoral site, but it really is not the first site of choice. So we always want to use the maximum barrier precautions as illustrated by the CDC. We want to try to incorporate the use of ultrasound to reduce the total number of insertion attempts because we as clinicians know that the more times that you have to attempt to stick and the more holes we make, the more room for migration of bacteria and the more risk of infection to that patient. And somewhat like the radial and the brachial insertions, we do site maintenance and assessment. And with the femoral, we as clinicians need to remember that distal pedal pulses need to be checked. Your feet cool and dry. Is there a capillary refill? All of that would be associated with circulation to the limb of the associated side. So that needs to be documented within your daily checklist. And then justification of site selection, just like with CVCs now, we have to justify why we would use a femoral site over something else, and we really should be justifying why we would use a femoral site for arterial line insertion as well. So steps that really matter for risk reduction, things that we as clinicians can do today to make a better outcome for our patients. So practice considerations. The National Patient Safety Goals encourage us to use mobile carts and pre-assembled kits. And these are available for every site, whether it's brachial or radial or femoral. And they're facility and organization specific. A mobile cart, if you don't have a mobile cart, I encourage you, there's a picture of one there, I encourage you to assemble one because it makes the clinician have everything that they need at their fingertips when they go procedure to procedure, and it increases their success rate for all vascular insertions. The femoral artery, again, is not recommended for insertion site for adults due to the risk of infection. I can beat that. I can keep saying that, and I hope that that message comes across very clear. And daily assess the need for catheter use and avoid the risk of infection. Just like the central venous catheters, we look at them every day. If they're no longer warranted, we promptly remove them. Length of dwell time directly is related to risk of infection, and we as clinicians need to manage those catheters, see them every day, and remove them as promptly as we can. And the other recommendation is to do not routinely change catheter sites to prevent infection, and this is really for the radial and brachial sites. Because the recommendation is also to move a femoral site if it's placed in an emergency situation, and maybe not under the best circumstances, to replace that to a radial or brachial as soon as those sites are available. So daily maintenance, what would that include? Inspect the insertion site. Look at the extremity temperature. Are they warm or cold? Are they both warm or both cold? Is one cold or warm over the other? Are there distal pulses? What is the skin color? And look for and feel for pulses above and below the insertion site. Note the presence of ecchymosis or edema and leaking and drainage around the insertion site, as that could increase or show signs of infection. Inspect the pressure monitoring setup to ensure the adequate waveform and accuracy. We don't want to leave catheters in that may not be accurate, so make sure that we're checking those systems. And then verify the integrity of the dressing. We as hospital organizations are being told dressings can move out now 7 days. We can use an impregnated patch and move them out 8 days. And the real challenge for us as clinicians is finding a dressing that works for our catheters in our patient population. So I encourage you to look out there and find what works best for you, because it also increases risk by pulling off the dressing and getting into the insertion site on a routine basis. Daily maintenance. Resolve difficulty with catheter performance. Again, we don't want to leave catheters in that aren't working. We also want to make sure that the flushing system and the mechanism is working. You also can question whether they're on heparin or no heparin. Sometimes that increases difficulties with catheters performance if they're a no heparin kind of patient, and we'll talk about that in a minute. Replace femoral sites when able. We always want to make sure that you replace that femoral site, and that's intentional, that we're aware that the femoral line was placed maybe in the emergency room, and it's not for trunk perfusion for accuracy. We want to make sure that those lines are moved. Verify continued need for catheter, and remove when clinically warranted. And then catheter removal. And this is the steps to remove an arterial catheter from any site, either radial or brachial or femoral. Explain procedure to the patient. Wash hands and don gloves. And remove the dressing. We try to avoid using scissors because we don't want to accidentally cut the catheter. Remove catheter slowly by pulling it parallel to the skin so that we don't irritate the patient. As the catheter exits the site, we want to make sure we apply pressure. Apply a pressure dressing to the site, and really if you're deseeing femoral lines, there's a couple things. One, the patient can vasovagal when you remove a femoral line, so you always want to make sure you have somebody else there with you. And two, you want to look at all the bleeding times of the patient to make sure that you don't need a femoral pressure device maybe to minimize risk of bleeding post-catheter removal. Inspect the catheter upon removal and ensure the entire length has been withdrawn, and that should be documented within the charting. And then document the removal procedure. And if I can just go back to the femoral pressure devices, we want to make sure that the patient still has pedal pulses when those femoral pressure devices are placed on. Because basically what we're trying to do is cut off blood flow so that the patient doesn't bleed out that site, but we still want to be able to circulate that trunk area or that leg. So continued practice considerations. So for flushing, follow your facility's policy and procedure and manufacturer recommendation for the transducer device. They're recommended a 4-day interval of changing the transducer. Follow the hospital policy and procedure regarding heparinized solution and use of normal saline solution. And I really advocate for the fact that we don't do blanket therapy, meaning not everybody gets heparin or not everybody gets normal saline. Each patient and each lab should be looked at and determine whether the patient gets heparin or not. If the patient has platelets, a normal platelet count, and all of a sudden drop in platelets the next day after an arterial line with heparin is being placed, then that heparin should be removed from those bags and we should be moving to normal saline. Each patient should be looked at individually. And with the risk of heparin-induced thrombocytopenia and the relevance of it today in the healthcare system and the problems associated with it, we should really be diligent in making sure that the patients who need heparin get it and the patients who don't get it. Dressing changes. These are generally a 96-hour interval, and with the use of the chlorhexidine impregnated sponge, these can go out to up to 7 days. Remember that within your organization, you need to find a dressing that allows you to be an extended dwell like that and be out 7 or 8 days without having to break and change dressings because the adhesives and stuff aren't working. We're really good at clinicians about advocating to maintain lines and keep the site secure and decrease the pistoning motion at the insertion site, but we really need to identify better dressings to allow that to happen. So securement. So we secure lines are less risk of infected, like I said, because of the pistoning action at the insertion site. So whether you use a Steri strip or whether you use a sutureless connective device, you really want to make sure that those A-lines are anchored into place. What we don't want to do is use suture. In my own experience, we haven't used suture in almost 10 years. Suturing, one, increases risk to us as clinicians because it's an additional possible needle stick, and two, it increases the number of holes in our patient that can actually get infected. So we really have moved away from securing with suture, and actually we secure nothing with suture. We haven't sutured any type of invasive line, hemodialysis central line, balloon pump, or arterial catheter in many, many years. So in regards to the pressure transducer, replace those at a 96-hour interval, and that one-way stopcock allows that to happen without actually going down to the insertion site and disrupting that beneath the dressing. And then the pressure tubing in the distal stopcock, as you can see in that picture there, you can actually shut the line off, remove the transducer setup, put a new transducer setup, and return the line on. And that concludes the arterial insertion care and maintenance webinar. And like Nancy said before, you can obtain a 1-hour contact hour through the saxtontesting.com and complete the post-test and evaluation form. And now we're going to open up to some questions.
Thank you, Amy. Very, very good. We have a list of questions here, and they range from insertion questions to complication management questions. So I'm going to start at the beginning with the insertion side. And one of our viewers is interested in understanding your thoughts on anesthetizing a point of insertion when a patient is sedated.
God, that's a good question. I believe, just like the theory that all of our patients can hear us even if they're not cognitive, I also believe that they can feel. So it's within my practice, and it depends on each clinical situation, obviously, I still anesthetize the area.
Okay. Next question. Any thoughts on arterial placement using the ulnar artery now that ultrasound is available? Preferences, ulnar or radial?
You know, I see more, I do see some ulnars placed, and it's normally because they've failed radial attempts, and that's really not the best practice. I do see the advantages of moving maybe up further on the arm on the radial, and possibly using the ulnar if you can justify flow, maybe possibly take a picture of the actual artery, put that into your medical record with the justification as to why you would have picked ulnar. You always have to remember, though, that the ulnar is the saving grace, and the ulnar protects us when the radial flow is diminished. So.
When you insert into the radial artery, Amy, do you ever have any difficulty in advancing the catheter even with good flow? And if you do, what could be the reasons for this?
I do, and you know, normally the reason for that, for not able to advance easily, is because you're in the side wall of the artery and not specifically right dead center in the middle. And a lot of ultrasound utilization or visual aid would help this tremendously, because there's a guide on the probe that allows you to see as soon as you enter the vessel with a pinpoint precision. I think anytime that I've had difficulty advancing a catheter, it's always because I'm either just into the artery, I'm not dead center in the artery, or I'm in the side wall of the artery.
And related to point of insertion, direct cannulation versus Seldinger technique, and from your perspective, is there an advantage one to the other?
Well, the Seldinger technique is the most common one used. The direct cannulation is risk for transfixion, which is going through and through, which could cause some complications. There are some studies out there that show that the Seldinger technique, especially in the women population, has better outcomes, and they're able to cannulate them more. I think that best practice, if I can say that from personal, is utilizing the Seldinger technique, because you have the advantage of having the wire and you're feeding over the wire versus trying to shimmy over a needle.
Let's see, there's so many good questions here. Do you use heparin in your pressure bags?
We look at each patient and we look at every platelet count every day, and in report, when we give line report, we give the history of the patient, what's going on with them, why they would or would not be using or getting heparin, and then we review all of their hematology labs to see if there's an indication to remove heparin. I think we're probably the most proactive, but I also am a clinician advocate for the use of heparin because I know it extends dwell time of catheters, and we actually have catheters that dwell for over 21 days without complication.
When you use a drape for direct cannulation, the question has to do with using a drape for direct cannulation of an arterial line versus inserting a peripheral venous cannula and not using a drape. Can you talk about justifying one over the other, or do you see them as different?
I do see them as different. A peripheral cannula, for one, it's always been an aseptic insertion, and the dwell time is generally 3 days. An A-line now, the dwell time, there's no dwell time specific per the CDC for arterial catheters, and the CDC really recommends that small fenestrated sterile drape, sterile gloves, hat and mask, and eye protection for radial insertions, and I really think that's related to the dwell time and the risk associated with arterial cannulation versus a peripheral IV. And that would go the same for brachial or arterial. And I think, depending on our patients, the process for IV insertion may change.
So let's move forward with drawing blood. And the question is, do you recommend the use of closed blood draw systems for ABGs and labs? And if so, why?
Absolutely. If you're not using the closed system like the VAMP system, you're doing old school practice. One, because we're no longer transfusing patients, and every time you withdraw a blood sample from an arterial transducer with a non-VAMP system, you have to waste 10 cc's of blood. So if you draw 10 blood samples in one day period, that's 100 cc's of blood loss for that patient, and we as clinical practitioners are no longer transfusing patients anymore. So the closed system approach is much more beneficial to the patient, and it also reduces risk of infection because it's truly a closed system throughout.
On the topic of stopcock changes with blood aspiration, there's curiosity about recommendations for those stopcock changes, and if you could elaborate more on that, our listener would appreciate it.
Well, anytime you break the system and draw blood, you add bacteria and dry blood to any area. And the dwell area within a stopcock, a three-way stopcock, is quite significant, and it's not a closed system. So it's recommended that you actually change the stopcock if drawing blood at a 24-hour interval to decrease risk of infection. That's why we've moved to the VAMP sort of system, remove that stopcock, and we've added the one-way distal stopcock to allow for the transduction changes without breaking the circuit.
When you do blood aspiration, how many mils of waste do you suggest before obtaining your sample?
10 mLs, and that's what's in the bladder of the VAMP system. So basically the difference between a traditional transduction system that you have to waste blood out of and a VAMP system is that the VAMP has a bladder and it holds that blood. It sucks it out and holds it into a bladder, and then you give that blood back to the patient. And for blood conservation and for the best of our patients and the risk related to transfusion, we really should be aligning ourselves with best practice as clinicians and using a VAMP type system.
Okay, this is a little bit in a little different direction, and it has to do with transporting patients for MRI and removal of or disconnection of the transducer. And how do you manage that in your practice?
Well, the patient has to be monitored, and I don't think I mentioned this in the webinar. If any time you have an indwelling arterial catheter, there's a huge risk for bleeding, especially if the stopcock was to be turned, if the transducer is removed. So in the case where it's continuously monitored and you go to MRI, because we know that in MRI the transducer has a little bit of a metal, so it can't go in, we would transport the patient being monitored. We would aseptically turn the stopcock, remove the transduction system, cap it sterilely, make sure everything's pretty sterile, make sure the A-line's been flushed, have the patient do their MRI, and as soon as they come out of the magnet and come out of that MRI suite, then we would reconnect sterilely, and most as aseptic as possible, and retransduce and then take the patient back to the room. We never disconnect and leave them disconnected for any period of time. We also don't not monitor sheaths at a cath lab, because the thought process is when they come out of cath lab and they have a sheath, it's going to be removed up to 2 hours. The risk is the patient's laying in a PACU or a post-care area and they can bleed out, and we would never know it because the alarm isn't going off on the monitor because the transducer setup isn't established. So just for benefit of the patient and risk, that all needs to be monitored.
Okay, we have 3 more questions, and these questions are more related to actual products. One listener mentions the fact that you mentioned you like to use an all-inclusive kit, and they're curious about why that is, and if you use all-inclusive kits for all points of insertion.
It's always recommended to use an all-inclusive kit, and really today with the National Patient Safety Goals and aligning strategy to be really successful for a clinician, to use an all-inclusive kit, it has everything for you within the kit to be successful. It reduces risk to the patient because it's aligned with a practice that's intentional. So yes, we have kits available for every insertion area. Depending on the patient, like I talked about the brachial line and utilizing a longer catheter, some of that has to be specific to your organization, but absolutely there can be custom kits related to generation or age specific or site location.
Okay. And do you see anything different, Amy, about different or unique about catheter material between an arterial catheter versus a peripheral IV catheter?
Well, the peripheral IV catheter has a lot of memory. So for an example, if you put a radial catheter in and it's a peripheral IV catheter and the patient bends or flexes or maybe is not the most compliant patient or maybe the patient has restraints on, once that catheter is bent, it has 70% memory, and the bend will always be there. So then it reduces the integrity of the catheter and reduces the integrity of the blood pressure coming through the catheter. The arterial catheter actually is a thicker material. It doesn't have the memory of an IV catheter, and it's specific for arterial use, and I think that's the biggest difference. It doesn't have the memory, and it maintains a true adequate blood pressure reading.
Mm-hmm. In your practice and in observations that you've made across the country as you've taught and consulted, do you see hospitals trending or tracking arterial catheter infection rates? And if they are, what kinds of corrective measures are being put into place?
You know, I think that with the CDC identifying and actually giving guidelines now in related to arterial catheters on all locations, I think hospitals are more aware. I think that the catheter-related bloodstream infections need to include arterial catheters, and I think that hospitals that know their rate or have that good surveillance in place are taking actions to reduce complications, such as adding that impregnated chlorhexidine impregnated patch, or doing more risk education, getting lines out and justifying teams that are just doing monitoring and maintenance to remove unnecessary, unwarranted lines. And I also think that if you're doing pan cultures on a patient for suspect infection, like you're doing the urinary catheter, you're doing the central line, an A-line catheter should also be included in that pan culture.
Mm-hmm. That's a very good point. Okay, and one last question. Are you seeing an increase in the amount of art lines needed due to the newer hypothermia protocols?
I do see a need, but I think it's a relevant need. These patients are acute MI patients who probably would justify and for titration of drips and for close hemodynamic monitoring. I also see an increase with the surviving sepsis bundle that we are placing arterial lines because we really are trying to hone in on a true mean arterial pressure. And with both of those protocols, the only way to get that true mean arterial pressure is through an indwelling catheter. So I do see an increase, but I think it's relevant, and I think with the use of strategies such as the central line bundle incorporation for arterial and the use of the draping and the use of max barrier, that even though we're seeing an increase on use, we're also seeing better preventative measures for catheter insertion.
Very good. So with that being our final question, I'd like to move forward with discussing and reminding of the opportunity for your continuing education units, which you will find more information at vesselhealth.org. Within the next hour, all registered attendees will receive an email with further instructions regarding the post-test and downloading your certificate. Please remember that this webinar will be archived at www.vesselhealth.org after the 13th of March and will be archived for those unable to listen in today, or perhaps those that might want to hear it again. We'd like to thank you for taking time out of your busy day, and thank you, Amy, for a most informative talk, and wish you all the best of the evening. Good day.
Thank you.